Okay, good morning, everyone. My name is Ellen Barra, and I'm an analyst with our Provider Outreach and Education Department for WPS. On the call with me today, or on the webinar with me today, is Tom Ryan, my friend and colleague, and he's going to be watching our chat. So any questions or suggestions that you have, you can place those into the chat. And then when we get to the question section at the end of this document, we'll be able to take those. You will also have at the end of this session an opportunity to take a survey, and we really do encourage you to do that. We want your feedback. We want this to be an excellent customer experience for you. If you're listening to this presentation through our encore presentations, you also have the same opportunity to provide that feedback. So we have just a couple of housekeeping things for you. On our Training Center webpage, which is if you go into wps.gha.com, you have in the top, you have Training Center. When you go into that web page, it provides you with all of our upcoming events, and that's called our live events. As part of that, it also allows you to download the material that we're going to be going through today. And then we keep our encore presentations on the website for about 60 to 90 days. The advantage to that is that you don't need a YouTube player if you're using our website. We know that a lot of offices really don't allow you to use YouTube in the office or on company equipment. And then at the same time, we also publish our encores on YouTube, and those will stay out there until we need to remove them for some reason. And then, of course, again, you can put questions into the chat function. And then again, we do encourage you to do that survey. The next slide that we have is just a disclaimer. Medicare rules and regulations do change often, and the CMS rules are what we have to go by. So if they change something, then all of the Medicare administrative contractors are going to change to that. Any questions that we respond to today will be based on the facts that you provide to us. But again, Medicare rules and your documentation are going to determine the final coverage. The next thing that we have is the CPT copyright notice. The American Medical Association owns the CPT codes and their descriptions. CMS, the Medicare Administrative Contractors, we don't own those. So this CPT copyright notice just really reminds you of that. And because of that, if for some reason you decide you're going to do something weird with any CPT codes that we have, we would really ask you to disconnect. We don't expect that you will, though. So what are we going to talk about today? Well, this presentation is going to go through documentation. So I've got about 5 different examples within the materials themselves. And we're going to go over what was in the medical record and then what procedure code we chose based on what was in the medical record. We worked with our medical review staff in order to evaluate the documentation. I'm also a certified professional coder. So between medical review and myself, we kind of came up with the procedure codes. Now, one thing I want to remind you of, though, is that if we are looking at documentation and we determine that the procedure code should be something different than what you have submitted to us, you have the right to request an appeal. What you want to do on the appeal, though, is you want to be very specific. So a lot of the appeal requests we get, it says, see attached documentation. Well, what you want to keep in mind is we've already seen the attached documentation and we've decided already that it's whatever code we determined. So what you want to do in these appeals is you want to show us. So you want to tell us on page 7, whatever is listed there, this equals this in a medical decision-making table. So you want to kind of direct us right to what you want us to see in order to support the procedure code that you have chosen for your service. Now, in the materials today, in some cases, I was able to actually use the material itself, was able to redact that and place it into the presentation. In some of these examples, though, the way the example and the documentation actually looked, we were not able to do that. So the first one here is one of those that we were not able to actually copy out of the medical record itself. So for this example, it's an office problem. So you can see here that the patient is coming into this provider to establish care with the provider. The information indicates the patient was there for right knee pain, and then it also includes the fact that the patient has had a knee replacement and then also a femur rod insertion back in 2016. Now you'll notice if you look at the next bullet though, patient is presenting for hip pain. So we're making an assumption for this that we really have pain, but we have pain in two different places. It also tells us here that the patient has tried over-the-counter medications, and this has really not worked for them. And I want you to notice here that it says for greater than 3 months. Okay, that's going to become important here in just a little bit. The next one that we have provides us with good information about the pain level. So it tells us the hip pain is currently moderate. When you're dealing with pain, that's a very good piece of information to provide, whether that pain level is simply intolerable or whether that pain level is mild, moderate, intermittent, whatever the case might be. So that next bullet point then gives us additional information about that pain. We have aching pain, but then depending on what that patient is doing, they're also getting some intermittent sharp pains. And it does say share there, and I apologize, it should be sharp pain. The pain is better at rest, but when the patient is up walking around, going to the mall, whatever, it does become worse. This is all great information to identify the level of that patient's pain. Then that next bullet point that you see, it identifies that the patient has had this greater than 6 months and it is getting worse. That's also very good information to provide because then it tells us the status of this pain. Now, 6 months into this pain, the patient is identifying that it's worse now than it was 6 months ago or 3 months ago. They're also telling us that it doesn't radiate and the patient does not have any numbness or tingling around the hip itself. Then they provide us with some history. You can see here the total right knee was done. The patient also had a fall in 2006, which, poor thing. But they had to have an open reduction then with an internal fixation. The provider has documented 30 to 44 minutes that they spent on this particular service. I will just let you know the documentation of 30 to 44 minutes is not the best way to go. Really, what your physician needs to be documenting is the time that they've spent on that particular patient. And if they're using time, they want to include both the face-to-face activities and the non-face-to-face activities that they took in order to take care of this patient. You want to encourage your providers to really pay attention to those non-face-to-face activities. You don't want to leave money on the table. So while the 30 to 44 minutes as identified here, it's documentation, it's really not your best choice to document time. And then we have information here on the exam itself. So as you can see here, the physician examined the hip. They're talking about the range of motion. They're talking about the tenderness to palpitation. They provided an Ober test, and you can see there that this is positive. So what that means really is that there's a IL or ITB, which is the iliotibial band, and that's tight. That's what positive means. And then they also mentioned there at the bottom the crepitus, and this is where the physician is hearing the grating, the crunching, or the crackling sounds when moving this particular joint. In the data, we see that the provider ordered a right knee x-ray, and then they reviewed the results of that x-ray. So here's their plan of care. So the diagnosis for this patient then is they do have ITB syndrome, which is again that iliotibial band, which is tightened up. We have a possibility of a referral to physical therapy. We have a medication that they have ordered. And then look at that next bullet point. The patient wants to continue conservative therapy at this time. So what that's telling us then is that this patient is not ready and does not want to start physical therapy right now. So the next piece of information, the next bullet point there, the patient was shown the ITB stretches. This is also great information because that physician then is supporting the fact that that patient wants to continue that conservative therapy, and yet they're still providing them information on what might work for that. They discussed, although they did not do, but they discussed a possible joint injection. And then they gave the patient a prescription for physical therapy should the patient want to choose that at some point in the test. One of the questions that we receive a lot of times is based on referrals. So you can see here in this plan, the physician has planned and thought about referring this patient to physical therapy. Well, this is not any type of testing. This would go into your risk category for the medical decision making. So what did we find on this one? Well, the problem is low. This could be 2 or more self-limited or minor problems. The practitioner is looking at both the knee and the hip, and they have pain in both locations. You would not count those as 2 different problems. Really, the pain is, or the pain itself is the problem. Since the hip seems to be the reason for the visit, you could also look at this as one acute, uncomplicated illness or injury. Well, this does not meet the level of moderate. We don't have a chronic illness because based on the AMA definition, a chronic illness has to have lasted at least 12 months or be expected to last at least 12 months or until the death of the patient. That information is not supported based on the documentation we have. In one place, again, that the practitioner mentioned 3 months. In another, they talked about 6. For the data, we have category 1 with the order of the knee x-ray and the review of the results. So this falls into the low because it's only one test that they did. The risk of the mortality or morbidity is low. There's no indication that there's a risk to the patient from that plan of care. Now, the physician has provided information about possible physical therapy, but there's nothing within that documentation that would support that this would be a higher level of risk. So the procedure code that we see here is the 99203. The provider also reported time, and the time reported was the 30 to 44 minutes. As we talked about, this really is not the best practice. A specific time would have been better. If choosing the code based on time, and if that provider did a separate interpretation of that X-ray, they would need to carve out that time. So you can decide, based on the patient, based on policy, whatever you determine, whether you want to use time or the medical decision making for each patient. It doesn't matter whether the physician has documented time. You can also use the medical decision making if that's the one that is more advantageous to you. Now, the next one we have is an inpatient resident service. So we have the author of our note is the resident itself. And then you'll notice on here when that was created. So the actual creation time of that medical record for this patient was on April 11th. We have signatures from the resident and the physician or the resident on 4/11, the physician on 4/12. So here we've got information from that medical record. It looks like the patient is getting ready to do surgery for the L3 and L4 laminectomy and discectomy. And then the patient had an informed surgical consent that was signed. Now, a couple of things just to kind of let you know about. Under that third bullet, where it says discussed risks and benefits, what was discussed? What's the risk to this patient from this particular surgical procedure? It also states in there all questions were answered. Well, what did they ask? That's good information to put in there because, again, it can help either support the time if you're using time in order to choose the procedure code. And then discussion of that risks and benefits, that can also go into the information as part of the risk for the medical decision making. Now, this particular service is not payable by Medicare. We have a resident involved and we have a physician involved. But the services by that resident and that physician were on different days from the appearance based on those signature times. There is no documentation to support that physician was present when the resident was performing these services. And so therefore it doesn't go under the regular teaching physician guidelines. And there is no information or modifier that was submitted to indicate that this could have been under a primary care exception under the teaching physician guidelines. So in this situation, if we're looking at documentation, Medicare would not make payment for this. The next example that we have is an inpatient admit and discharge procedure code. So we can see here that the patient was admitted on 4/19. They were discharged on 4/20. The history and physical by this practitioner was done on 4/20, and then it provides us with the chief complaint. Short of breath with exertion, pulmonary effusion. The patient had COVID a month ago. Now, that last bullet is exactly what came out of the medical record. So you can see here that there's no information on the minutes that were spent in admitting this particular patient. So this medical record we're actually able to redact and then kind of bring into this information. So this tells us that the patient presents for short of breath, and the patient did come in through the emergency room. The patient has dyspnea, labored breathing on exertion. They're identifying generalized weakness, and the patient can no longer walk to her barn without stopping to rest. The patient did order or called for an ambulance yesterday. So again, this is our service on 4/20, patient was also at the hospital on 4/19. So we want to keep those dates in mind. The ambulance service did administer a breathing treatment. The patient is admitting to dizziness, cough, bilateral lower extremity edema, and then fatigue. And then I like one of the statements in here. It says the patient, or it also indicates the patient received 3 units of blood within the emergency department itself. And the statement I like is on the next slide. So the patient states now that they're feeling much better after receiving the blood transfusion and the Lasix. The severe palpitations have stopped. She has been ambulating without shortness of breath, lightheadedness, dizziness, and she is eager for discharge. And then her main complaint now is how bad the food in the emergency room is. I think this patient's kind of a pistol. So we did have additional information within the medical record. The physician did perform a medically appropriate exam for this patient. The blood pressures were good, the oxygen levels were good. The patient's in no acute distress today. Provider did review multiple lab tests. I didn't include those because frankly the list was pretty long. And then the physician reviewed the chest x-ray from 4/19. So you can see the plan of care here for the patient. One of the things that the physician proposed was a bone marrow biopsy. Again, the patient had a major transfusion of blood there, so there's, kind of got to be something going on. But the patient declined that. The patient was instructed to stop one of the medications, the Eliquis. The patient has respiratory insufficiency, but on this is what it's telling us, but the previous information showed that this had resolved. The patient has generalized weakness. The patient does have COPD. So in the discharge information here, we can see that now it says I have spent 50 minutes on the patient's care. That's great information to receive. They're specific. They're not using any type of range. And so therefore Medicare can kind of center in on that 50 minutes. Now this particular claim was submitted to us as a 99236. A 99236 is an admit and discharge combination procedure code. So the admit and the discharge should be happening on that same day. Well, this is not correct as the provider didn't see that patient on 4/19. There was actually another physician who admitted the patient on 4/19. And again, the documentation did not show us how long the patient was an inpatient. We, excuse me, we know that the patient was in the ER before they were actually admitted, but we don't have any times. And times are part of the documentation requirements when you're billing that combination procedure codes. And again, the documentation shows admission by one provider and discharge by another. However, the provider can submit the 99239 procedure code because they have documented more than 30 minutes. So that procedure code would be valid. And if we were looking at this, then we would be able to allow that as a 99239, but not as the admit and discharge procedure code. So the next one that we have, and this has a lot of information here. This is also an inpatient service. Now the patient was admitted on September 28th. And so look at our date of service here. We're now at October 7th. So the patient has been in the hospital for a little bit of time. We see here we have the reason for the visit as sepsis and colitis. We've got respirations at 27. Patient is intubated. We have no remarkable fever. It's showing that the patient's temperature is the 99.3. So then if we continue on, look at this problem list. I think this is kind of everything that the patient has ever had. This is not the documentation that we're looking for. What we're looking for in the documentation is what is your practitioner treating the patient for today? What is the illness or injury or services to affect a malfunctioning body member? What is your physician or practitioner dealing with today? Now, when you also take a look at these, at this problem list, you'll see some in there that really could be duplicative. We have diabetic neuropathy associated with type 1 diabetes, and we have type 1 diabetes with diabetic autonomic neuropathy. We also have neuropathy listed. So are we simply kind of adding those in? Are we bringing those in from a previous medical record? But again, it goes back to what's the physician treating that patient for today? So our question in looking at this and in looking at the documentation is, are these active problems being treated by this physician on this individual data service? And you can see here, if you go on to the next one, we have more problems that are listed. Now, if you look here at the ketosis, you'll see that HCC there. That stands for the hierarchical condition codes. These are these are diagnosis codes that are mainly used with Medicare Advantage plans to show the additional complication of the patient. But are we treating that? Is that affecting our service today? So that's one of the things you want to be looking at in the service that we're providing for the patient. If we're treating, the a particular diagnosis, and there's another diagnosis that's going to affect our diagnosis today, what we're actually treating the patient for, then include that. If our diagnosis and what our plan of care is going to affect another diagnosis that the patient may have, and so you're having to consider that, then include that also, because your physician's work is going along with both of those particular diagnoses. If you go back and take a look, you'll notice that sepsis and colitis were not listed in the patient's problem list. So again, what we're looking for is, what is the physician providing to that patient on this particular day? And then we have inpatient lab results. We have lab tests that were done on 10/7, and so we can count those if they were ordered on 10/7, and then we can count the review of those, which is part of the order. You would not count those separately. The culture is dated 9/29. So that one we would not count as ordered or reviewed because that's already been done. The practitioner did document that they reviewed these results. What we're wanting to see in the documentation is how these laboratory tests or other testing that may be done for the patient, how is that really incorporated into that plan of care? Then we have IV medications that the patient is doing, and they're treating the patient with an IV of the, I can't pronounce that, meropenem, but it didn't start today. So you can see there that it actually started on 9/23. So then we have the patient summary. So the patient was in pretty bad shape when they were seen in the ER on 9/28. She was septic. She had a white blood cell count of 1.7. Now that was from 9/28, though, not today's date of service. And then the CT scan that was done happened on 9/29. Again, not today's date of service. So the next slide that we have here is our inpatient impressions. So you can see that it does indicate septic shock, but our other documentation didn't show that the patient was still in septic shock. So is this actually an impression coming from the ER or from one of the first couple of visits that the patient had? That's what we want to be looking at again, what's happening today for that patient. The patient is still intubated, and it does identify that a sigmoidoscopy had been done on this patient and is not consistent with the colitis. The colon edema is likely coming from the white blood cell or white blood cells and shows the decrease to the 16.9. Cultures are negative. They indicate that they're going to continue the medication through 10/8, and then they'll observe and will determine from there. So what Medicare found on this one, we determined that the problem was moderate, the acute hypoxic respiratory failure. This is one acute problem with systemic conditions. The documentation identified the patient had hospital-acquired pneumonia and was intubated. We have a moderate level of data. We do have testing that was provided for this patient. There is information in there about the comprehensive metabolic panel. However, there's also information that not all of the comprehensive metabolic panel tests were performed, only a couple of those out of there. So what you want to look for when you're looking at that testing are unique tests. And basically this goes by the procedure code until you get into the situations of the lab panels or bundled services. So for an example, if they had done all of the testing within that comprehensive metabolic panel, you wouldn't have counted all of those separately. You would have counted one for that comprehensive metabolic panel. So one question that we received is, when do you count the test? When it was ordered or when it was reviewed? Well, the American Medical Association states that when tests are ordered during an encounter, the review and order are counted together. So counts as one element of data. It does not count as two. Now, there is information within the AMA information within the CPT book that if you're reviewing tests that are ordered by someone outside of your practice or inside your practice, not your specialty, then you could count the review. We have no information within this medical record to support that. Therefore, the review goes back to that order. And then the risk information here is low. There's really no information concerning the risk itself. The provider states continue nutrition and supportive care, continue that medication, will continue to follow and advise. So what we're looking for in the documentation is that physician's clinical idea on the risk to the patient from the plan that they're doing. When you get into inpatient services, especially where you're seeing that patient on a daily basis, what is the risk from the plan that you've determined today? Now, based on this documentation, the plan today is pretty much the same plan from yesterday, but document that risk. Document what the physician is thinking about in determining that risk for that patient. And then the next one that we have are critical care problems. So again, you can see there's a lot of problems listed. Some of these also are identified by that HCC. Um, the Medicare fee-for-service is only going to consider those when the documentation shows how they affect the problem today. Are they the ones that are being addressed? Are they affecting the problem that is being addressed today? So this particular patient was admitted for a CABG, the coronary artery bypass graft. So we have information on pain, and this is from the CABG itself. They are determining to continue the prior to admission medications. We have information on the cardiovascular. We have information on respiratory. They're removing the tubes on our date of service. This does show lung or low lung volumes. We have a Foley catheter that will be removed the following day from this visit. They're continuing to hold the warfarin. The A1C is at a 6.1. Activity level is ambulating in the halls, nursing, and cardiac rehab. Okay, so let's think about that. The patient is ambulating, they're getting cardiac rehab, and we're billing for a critical care service. So what we see here on the data is the glucose rates are coming down, which is good for that patient. The pro time result, 2.1, it's still higher than what they want. And then it shows that the physician reviewed the chest x-ray. So then the provider indicates that they discuss the patient with the critical care attending and the surgeon. Okay, so it provides us with information. Patient is critically ill and at risk for life-threatening deterioration. We didn't find this in the documentation. From the documentation, this practitioner is treating those conditions listed as active. So that leads us to the question, what's really happening here? Based on this documentation, who is this provider? Because, again, it says they've talked with the critical care attending, they've talked with the surgeon themselves. So what is it that makes this practitioner service medically necessary? So postoperative services should be taken care of by that surgeon. Unless they're transferring care, the reimbursement for postoperative care, which includes pain management, is the surgeon's responsibility, and Medicare is making payment for that. There's no information as to the specialties of the providers that were involved in the treatment. If this was a critical care service not related to the postoperative care, then the modifier FT should have been reported, and it was not. So the CERT contractor is the one who reviewed this one, and you can see here they downcoded this. They did not agree that this was a critical care service, and the documentation really doesn't support that. We know we have at least 3 different providers involved, and just based on the documentation we have, it's very difficult to determine who's doing what with that particular patient. So again, they downcoded this to the 99233. They did identify that the problem was high. The documentation supported 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. The patient's A1C level is higher than it should be, and that could be the results of the CABG. We also have that the patient has Parkinson's. We have information on the data. They're reviewing lab services and chest x-rays. And we have a discussion of patient care with other practitioners. So this then would fall into the moderate risk. The provider has given instructions on ambulating the hall with nursing staff, and they're now suggesting that cardiac rehab can be involved in this patient's care. So that's the documentation that we have to provide to you. So we do have some pre-submitted questions that we'll go through before I open it up to Tom. One of the pre-submitted questions is, well, what about macros and scribes doing pre-charting? Well, using macros themselves, the idea of that is not a bad thing. However, you want to make sure that that macro accurately reflects what you did for that patient today. Again, we go back to identifying a range of time as opposed to the time that was spent by that practitioner. And then when we get to pre-charting, if the scribe is pre-charting some type of history that's gathered or something like that, that's okay. However, if they're pre-charting what they think that the physician or practitioner is going to do, then no, don't do that. The documentation needs to be accurate for the service that was provided to that patient on that particular day. Another pre-submitted question we had was, what about using a digital optical identifier or DOI? And you can use tools in order to make your documentation easier. The physician, however, has to verify the use and then any response that was provided. Another question is, what about greater than or less than time statements? And this goes back to, that's not your best practice. Document the time that you spent. Is the statement continue current meds acceptable to determine a problem that was addressed? And the answer to that depends on your documentation. If you have one problem and that's the only one listed, then yeah, that would be fine. If you have multiples, then no, it really wouldn't. You would need to identify the problems, identify, are they better? Are they the same? Are they getting worse? Whatever the situation is. So Tom will go ahead and open it up for questions here.
Sure, we're going to start with the questions on example one, and I will tell you that there were quite a few questions. I'm going to try to combine them into a couple. So the first one is, if an x-ray is ordered and reviewed with patient care, would we count the order and review? Wouldn't this one x-ray be considered SF or minimum, not limited?
No, okay, say that last part of that again, Tom, I'm sorry.
So the question mark ends after order and review. The next statement, wouldn't one x-ray be considered SF or minimum, not limited?
Well, the way that we adjudicated this is, let me get back to my page there. We identified the data level as limited because they had the one x-ray. Because you don't count the review and the order. If you're ordering the test, that is, it counts both the order and review together. So we had this as limited.
Okay, so we're going to keep with example one. And then the next question is, would the prescription for, oh gosh, meloxicam be moderate risk and be counted as RX management? Just trying to read through to make sure that it goes.
That's okay. And this one is one of the ones that providers are really having trouble with. Okay, the fact that you address a medication, keep the medication the same, order a new one, discontinue one, change dosage, does not necessarily mean that your risk is moderate. If you look at the AMA guidelines and in the CPT, it identifies those items listed in the risk table or in the risk element as examples only. So what Medicare is going to look for is what is the risk as identified by your clinician for this patient. I don't know specifically what this medication is. If this is a medication that could cause severe side effects and you're giving instructions on the patient on what to watch for, you're giving instructions on the patient to watch for any interactions between other over-the-counter things they may be doing, other medications, then that could increase the risk. But based on the documentation that we had for this one, we determined that this was low. Next question.
Okay, so this goes back to that same, this is a full like scenario thing, so hopefully I can get all this for you. For example, one, I would like your feedback because I'd argue billing this as a 99204 without time documented. The patient patient meets moderate MDM for element one or more chronic illnesses with exasperation or side effects of treatment. The chronic hip pain is getting worse. The patient meets elements 3 for a moderate level of risk, RX management, prescription for patient. Would not consider this a low risk if untreated. Discussed joint injection, not an OTC drug. This meets 2 out of the 3 elements for a moderate level of MDM.
We disagree with that. Now, again, remember, sorry, Tom, I hit mute for some reason. Based on our evaluation of this documentation, we believe that it is a low problem level. Number one, we don't have the definition of chronic. Chronic is 12 months. So there's nothing in the information that tells us the patient has had this pain for the last 12 months. There's nothing in the information that tells us the physician expects it to last at least 12 months. When we're talking about the risk level, again, the fact that the physician dealt with a prescription medication does not always mean that it is moderate risk. Sometimes it could be high risk, ordering a particular medication for the patient. In this situation, we determined it was not. Now, again, I want to remind you, if you disagree, if you got this answer back from us and we downcoded your service, then you can request an appeal and you can point out to us the things that you believe support the procedure code that you submitted. We will have an additional staff member that reviews that. They may agree with you, and then we would reverse our decision. Based on how we looked at this, though, this is our decision at this time. Next question.
Okay, going back to the patient's example 2, the statements of risk and benefit were discussed and all questions answered. That's in quotes. You commented that we would want to see more information documented in order to give the provider credit for column 3 risk. Can you give any examples of what you would want to say specifically or how we can communicate that to our providers? Also, are you giving any credit, even negligible risk or below average risk credit to column 3 without the current documentation or with the current documentation, sorry.
No, that's okay. And what we're looking at and what we're looking for is the clinical determination of the risk from the surgery that's going to happen for this patient. Okay, all surgical procedures, whether you're doing an injection into the joint all the way to, heart transplant or something like that, all of them have risks. And those risks for that specific procedure are fairly standard for each of those different procedures. What we're looking for in the documentation to support the risk is how those risks go to this patient. So for an example, we'll just take an injection into the joint. But if you look at information on that, you could have redness at the site, you could get an infection, you could have pain at the site, all of those types of things. Okay. So that's not necessarily what we're looking for. What we're looking for is how do those risks affect your patient? Now, that doesn't mean to say that an injection into the joint, as an example, could not be a high risk for the patient, but what else is going on with the patient that would make it that high risk? Next question.
Example 5, can you please explain more and about the moderate risk? I'm not understanding where ambulation in the hall and cardiac rehab counts as a moderate risk.
Okay, for this one, the number one, the information on this one was fairly confusing because we have a provider who's billing for a service, and if the patient is ambulating without additional documentation, are they critically ill or injured? And that's in order to bill critical care service, the patient has to meet the critically ill or injured definition. In addition to that, the physician who is providing that service has to be providing critical care. So, for an example, in this one, we really don't find where this physician is performing critical care services for the patient. And again, this one was reviewed by the CERT contractor, the medical review staff, and myself. We reviewed these also, to use for these examples today. So the documentation simply didn't support a critical care service. Next question.
If knee and hip surgery should have at least 3 months conservative treatment, then physical therapy is not considered conservative treatment?
I'm sorry, Tom, I don't understand the question. If we're talking about example one, um, that piece of information was really good because it identified the proof of thought for that particular provider and what he's doing for the patient. Um, so I think on example one, the physician suggested physical therapy and the patient decided not to do it. The patient simply wanted to stay with the conservative therapy, exercises at home, and then the medication.
All right. Michelle, if you need more on that, please put that back in because all I have is a statement that I read you.
Right.
Ellen, I'm going to go on to the next one if that's okay.
Yes.
Okay. On a subsequent hospital encounter, the following is documented. GERD, oh gosh, pantoprazole 40 milligrams daily, hyperthyroidism, letharothazine 25 mcgs, I'm going to guess milligrams also. There is no additional information. Would these conditions be considered as problems addressed?
If there's absolutely no other information, probably not. What we want to see is this what your physician addressed? Because again, when we're talking medical records within a hospital situation, you can have multiple physicians that are involved in that patient care. If your physician identified they were treating the GERD, they were treating the thyroidism, whichever way that went, and this is their medical decision for that patient to have them either continue or start these meds or whatever, then yes, we could count those as problems. And then we would look to the documentation to see how that physician is classifying the risk to that patient for the choices, the medical decision plan that they actually made for the patient. And Tom, we can take one more.
In a subsequent hospital encounter, the patient was admitted for pubic fracture. Ortho is managing the fracture. The hospitalist is managing the chronic conditions. Should the fracture code be included in the hospital diagnosis list for that encounter?
No, not if they're not treating that, and if that particular fracture is not affecting anything that they are treating, or what they're treating and their treatment plan is not affecting that fracture. What we want to see in the documentation is not the kitchen sink, okay? What we want to see within that documentation is what is your practitioner doing today during this encounter for this patient? What are the problems that they're addressing? What are the data elements that they're accessing? And then what is the risk to that patient? And especially when you get into a hospitalist situation where you have other practitioners involved, then that hospitalist really needs to be careful within their documentation to show why their services are medically necessary. Not, I'm just the hospitalist and I need to see them because the hospital, that's their rules. But why are my services medically necessary? So, Tom, that will be the final question that we'll take for today. We will receive a report back from our WebEx platform on any questions that we were not able to answer today. And we will take a look at those. We will respond back to you, to all attendees, on those particular questions. So now let's go on to our next slide. You're going to be getting an email here in just a few minutes to thank you for attending. And Tom and I thank you for taking time out of your busy days to come listen to this. This is your certificate of achievement. It will identify the title of this webinar, the date, and then the contact hours for this. If you don't see it within the next probably 10 minutes or so, check your junk or spam folders. If you have called in, then obviously you won't receive this, but you can contact our email box, and then you can let us know the telephone number that you called in from, and then we'll be able to send you a certificate. We will be able to take follow-up questions for the next 7 days. And the email box is listed there for you, and Tom has placed that within the chat. We can't take any claim-specific questions. We don't have access in provider outreach to the claims processing system. So any claim-specific questions will need to go back to our customer service area. And we do want to know what you think. We're interested in your feedback. If you believe that I did a good job in providing this information to you, then let us know that. If you think that there's ways that I could improve, then let us know that too. The results from the survey go to CMS as part of WPS reporting. It also goes to our management staff, but then us as analysts, we use that information to help make our presentations better. So the survey link is in the chat. Once you leave the webinar, WebEx is going to provide you with a different screen. And what WebEx is telling you, and this is what the little white box on the right-hand side of your screen shows, it's basically telling you that WebEx says the host, or WPS, wants you to go to this other website. So if you hit the continue button, that will take you directly into that survey. So on behalf of Tom and myself, we just want to thank you again for attending today. Again, we will have this presentation available as an encore presentation and available on our YouTube channel. We really encourage you to complete that survey. One of the things that you can identify in the survey is what additional education you would like to see on this topic or any other topic. So this concludes our presentation. Thank you so much for being here. You can now disconnect.